Right, Copper, I think you just need to share screen again, if that's all right. Hello, everybody. We're just going to give a couple of minutes just for people to join us as we're joining. So I think it's 6:59 here in the UK. I know a lot of people are joining us from all around the world. So very grateful for your time this evening or this morning or wherever we are. So we're just going to wait for the numbers to tick up a little bit. I think we should have some good discussion tonight, actually, because I think there's quite a lot of numbers joining us, hopefully, for the webinar. So we'll have loads of questions and answers at the end, and I'll go through that as well. But I'm hoping, certainly I'm fascinated with this talk today, because it's one of these areas that is not my area of expertise, but I'm very interested. Okay, we'll just give it a few more seconds. Okay, great. So it's 7 o'clock UK. Thank you for joining us wherever you are all around the world. My name is Richard Artingstall. I'm Director of Teleconsulting at VET.CT. So I have the privilege of leading our consultancy team. We're made up of about 55 specialists in 11 different disciplines. VET.CT itself is bigger than that, and I'll go into a little bit of detail today. So I'm really pleased to introduce today Copper Aitken-Palmer, a really good colleague of ours at VET.CT, exotic specialist, and we're going to be talking about rabbit ileus and stasis today. But just before that, Copper, if you could just move the slide on, that'd be great. I just want to give a bit of context of why we're doing these talks. We're doing a talk every 2 weeks. This time in the evening here in the UK, all of our different disciplines. So far we've had chemotherapy, we've had internal medicine on leptospirosis, we've had emergency dental treatment, and we've had neurology with vestibular syndrome as well. So it's been fascinating. And we've got lots of specialists lined up over the next few weeks up until July. So we'll give you some information about how to sign up for those at the end. But really, this is to highlight and introduce, and for you guys to get a feel for our specialist team. Like I said, in the consultancy side and the teleconsultancy side, we've got 55 specialists, 11 different disciplines. But VET.CT itself has got a global team of over 200 specialists. And what we really pride ourselves on is that exceptional radiology, X-rays, MRI, CT, ultrasound, giving specialist advice to people all around the world in different practices, in different clinical settings at that point of need. And we've also got an education service as well. So we work very closely with universities, students, giving student teaching as well, guiding that next generation. And it's really close to our values to sort of be a shining light for the profession across the world. So with regards to the specialist teleconsulting, this is a new way of working for a lot of people. Essentially, we give written advice from all of our specialists, and it helps you treat cases in-house. You can access us through various different means at different times of the day, depending on what shifts are on and stuff like that. It's written specialist case advice in a regular time frame within 12 to 24 hours, often much sooner than that. You can access us through text, through appointments, phone calls, and written advice, so it depends on the discipline. If my phone works, which it should do today as well, I just want to show you as well, we've got really, within that, we've got unlimited follow-ups. And those case notes and advice will be very detailed, and you can add those to the file as well. And you can start to share them. We're developing a sort of product that's coming out that you can share them with clients as well, and you can start to use that as a client discussion as well. So excuse me while I just boot up the VET.CT app, because what I want to highlight as well is that there's a really good way of accessing us through, especially for exotics. So if you, I'm going a bit blurred, but there's a VET.CT app. If you go to the Google Play or the App Store or anything like that and do download it, and that's essentially like having the platform to access us on your phone. You can access us through a desktop platform, going through the website or on your phone. But that enables you to take photos, especially with those tricky exotics cases that are often in different environments. and within the practice as well and outside the practice, so we can add photos. So it's a really good way of interacting with us. The big thing about teleconsulting service and the consultant service is that clients love it. They're delighted to stay with the vet that the vet that they know and trust. And it really does reduce that uncertainty around decision making. And we look at it very in a collaborative way, especially in exotics where things are more complex. There's lots of different ways there's lots of different species that we treat. And the references and the techniques are also varied. It's a massive, massive discipline. So please, use us. You can either take up a subscription, an individual subscription, or a practice-led subscription, or just use us one by one, really, as a pay-as-you-go use, and then get a taste for using us. So if you've got your phone, download the app and have a look at us. Scan that QR code as well, and come back to the webinar and scan the QR code. That will give you information about how to access us. So next slide, if you can, please, Copper. So with that in mind, we're going to be doing a demonstration webinar on how you can get the best out of us for specialist case advice. And I think if you want to email me directly, I'll be really interested to know if you'd be keen for that webinar. So my email is richard.artingstall@VETCT.com. So I'm more than happy to field any questions there. Okay. Next slide, please, Copper. So just a bit about the talk today. It is going to be recorded. Everybody will get a link to the recording directly after this. So no need to worry if you're frantically taking notes or you miss anything. Everybody's going to be on mute just for this webinar. And there's a Q&A box at the bottom. If you've got any questions, pop the questions in there as you go along. Each webinar has generated multiple questions. I'm sure this one will. And what we'll do at the end, I'll go through the questions and Copper can articulate. So that's the chance to get those questions as well. If you've got any questions afterwards, just email us, contact us, use us, and we'll be your partners in clinical work as well. So next slide, please. So delighted to introduce Copper. Like I said, Copper's an integral part of our team. She's joined us from Florida today. She's an incredible diplomat in zoology and clinical zoology. How would you describe it? Like, it's not zoology, it's zoology.
It's technically a diplomat with the American College of Zoological Medicine, which covers all species. So a lot of people think of rabbits as just exotic pets, but for our board, everything is covered. Rabbits, rhinos, giraffe, you name it.
Yeah, very broad, very expertise. So what we do, Copper's going to be talking about rabbit ileus and stasis, and I'll hand you over to Copper. So thank you, Copper.
Thanks. I am excited to talk to you all today about this topic. I realized just how important this topic is because I was kind of thinking through cases, thinking about rabbit ileus, obstruction, stasis syndrome, thinking about some that were liver lobe torsion, gastric dilatation, and volvulus. And as I'm thinking through them, I was thinking, do we even see rabbits like for other things? Like, have I even seen a rabbit that wasn't a GI dysfunction, wasn't some motility issue? And then I remembered sometimes we do see them for eye issues. And then I thought of another case of a rabbit that came in, which is terribly overgrown incisors, like they are growing right up into his nose. Got those trimmed pretty easily. And then I thought, well, that one's just half a step away from becoming a GI ileus. So that just kind of reminded me how important this topic is. So I'm very excited to talk to you all about it today. And to start, I wanted to talk a bit about just how unique the gastrointestinal tract is for rabbits. And this schematic, I think, has been published and published again. It was, I think, originally in the textbook of rabbit medicine. It's just a great one showing all the aspects of the rabbit gastrointestinal tract. But I do sort of wish that they had put the teeth in there. So rabbit teeth are so critical to normal GI motility. And that's because we know the rabbits need high fiber, the grass that they eat or the grass hay. In order to consume those appropriately, the incisors cut the hay, cut the grass, and then the cheek teeth really grind down those fibers. And if they don't have normal occlusive surfaces opposing in those cheek teeth, and they're not grinding down that hay appropriately, and those fibers are too large and they're not processed appropriately in the GI tract, which sets them up for issues with GI dysfunction. We also know that rabbits have this big cecum here, kind of over brought out of the schematic. And I just wanted to remind you that that cecum in the rabbit holds 60% of the gastrointestinal volume. So that's a huge amount. A lot of it is water. And rabbits have a lot of water throughout their GI tract. And that's important because it helps them move that fiber through. In the cecum, it allows for the microbes to break down those fibers, producing various vitamins. And this is important to remember because rabbits really need a lot of water, and they need a much more amount of water than a similar sized mammal. And so that's important to remember. When the gastrointestinal tract is not working properly, it's probably because it's dehydrated, at least in part. Often a rabbit will become dehydrated in their gastrointestinal tract before you can see outward signs of dehydration. So before there's a skin tint, before the eyes are sunken, before there's a prolonged capillary refill time. So if you're seeing a rabbit for any sort of GI issue, assume it's dehydrated. The other thing that rabbits need are cecotrophs. So rabbits need to be consuming the cecotrophs, which are those little packets of microbes and vitamins that are put out from the cecum. They're consuming those first thing in the morning directly from the rectum. And if a rabbit is not consuming the cecotrophs and the owners are seeing cecotrophs, then there's probably some sort of GI dysfunction. This is an early warning sign that if there isn't now, there will be soon, because if they're not consuming those cecotrophs, it sets them up for problems. I also wanted to point out with this little arrow right here, that the stomach, even though we think of the stomach as quite large in rabbits, it only holds about 15% of that gastrointestinal volume. And it is normal for the stomach of rabbits to always have some ingested in it. So keep that in mind when you're looking at radiographs, and we'll talk about that more. So you have a rabbit coming to you and it hasn't been eating normally or hasn't been eating at all. Maybe there's not very many feces produced, or maybe none. The question is, how long has this rabbit been abnormal? When was it last normal? The other key question for the history is the rabbit producing any feces? If the rabbit's not producing feces, this is going to have a worse prognosis and need perhaps longer therapy, more aggressive therapy. Because if there's no feces, then that means that gastrointestinal tract may be completely stopped, or there's really serious ileus happening. So I have a picture here of a rabbit in a crate with some fecal samples and some litter and some hay. And that's just a reminder that rabbits should be producing feces kind of all the time. Often when rabbits are coming my way, they've been in transit for a little bit. Maybe they've been waiting in the lobby. I always check the carrier that it was brought in to make sure that there are fecal samples in there. There should be some in there. If there aren't any pellets, this rabbit has for sure slowed motility and may actually not be producing any feces, which is a worry, right? So anytime a rabbit comes in with some sort of gastrointestinal issue, the first goal is to stabilize them medically. And to stabilize them medically, you're going to want to stop the pain, get them rehydrated, maybe start them on some antiemetics, check the blood glucose, and check the body temperature. And those are the elements to remember when you're first looking at them. So when I have a rabbit coming in and it's got anorexia, hyporexia, not producing feces, some sort of abdominal pain, whatever it is, the first thing we're doing is getting a body weight. And the reason we get the body weight is because this is how we're going to evaluate dehydration and evaluate its return to hydration. So ideally, you have a historic body weight for this rabbit, so you can get an idea for how much it's under body weight. If you don't, you're going to use this body weight at entry to help you as you monitor its body weight as you rehydrate this rabbit, because you want to see it gaining weight as you rehydrate it, to know that you are rehydrating it fully. We're going to assume these rabbits are coming in between 10 and 15% dehydrated. So you're going to want to see a 10 to 15% increase in body weight as you work to rehydrate this rabbit. The next thing is getting a rectal temperature. It's important to get the rectal temperature because you want to know if this rabbit is normothermic, hyperthermic, or hypothermic. Because the rabbits that are hyperthermic or hypothermic are rabbits with worse prognosis, more severe disease, and they're going to need additional diagnostics. Go ahead and auscultate them, listening for murmurs, listening to the respiratory sounds, palpate the abdomen, looking for painful areas, and check the CRT. So those three are the first things we do for rabbits that are coming in for GI issue or ileus or stasis. The next is go ahead and start sedation analgesic. So this might be feeling kind of early, like we haven't even completed the whole exam. Like, why are we doing sedation analgesic? Well, these rabbits are coming in stressed because they're in the hospital. They already have some GI dysfunction because they're in the hospital. Maybe they have some amount of stasis, or they have pretty severe stasis. So they need analgesic because we really want to stop the pain. If we can stop the pain for these rabbits, then that GI tract is going to start moving. And so we want to do this early on in the process. This is also going to help because we're going to place an IV catheter in these rabbits. So after you give sedation and analgesic, go ahead and finish your exam. Now's the time to look in the mouth. This rabbit's sedate, you're going to have an easier time of looking in the mouth. Go ahead and palpate the abdomen again, see how they're feeling. Is the pain repeatable? Finish your exam overall. And while you're doing the exam or shortly after the exam, go ahead and start them on some subcutaneous fluids. Again, you're probably thinking like, wait, it's kind of early. Do we really need it? Again, we're assuming these rabbits are coming in 10 to 15% dehydrated. So go ahead and give them the subcutaneous fluids. Some of them have been in transit for a while. They've been waiting in the lobby, so they've not had the opportunity to drink if they wanted to. So giving them the subcutaneous fluids is actually going to give them a jump on getting them hydrated. Sometimes I'll actually give subcutaneous fluids after the rectal temperature. If I can't do the exam right away, go ahead and get some subcutaneous fluids going. The next step then is hopefully the sedation and analgesic starting to kick in. So now you want to go ahead and place the IV catheter and obtain a small blood sample when you do that. Now you want the IV catheter so you can start the CRI of lidocaine. Again, you're probably thinking like, wait a minute, this is early. This rabbit just came to me. Start the lidocaine early if you can. Start the IV fluids early if you can. And the reason for that is it's going to improve the outcome. So there's been a couple of studies now that are showing that lidocaine is very helpful in these rabbits for any sort of GI dysmotility, and that it improves their outcome. I forget the statistic exactly, but I think it's something like 7 times more likely to have a good outcome if they receive IV lidocaine. So go ahead and plan and start it early. Get those IV fluids going, and then go ahead and consider antiemetics. And the earlier and better you can stabilize these rabbits medically, the more likely they are to have a good survival. There's a study that looked at a whole bunch of obstructed rabbits. I forget how many were in the study, but they found that about 90% of them could be managed medically and had good survival. So the key though is to do all of these things pretty early in the process. All right, so 3 essential diagnostics to do early are checking the hematocrit, checking the temperature, and checking the blood glucose. So we talked a little bit about the rectal temperature. Now, the rabbits that are hypothermic are a worry. They're either hypothermic for one of 2 reasons. One, they may be severely dehydrated and they're not perfusing appropriately. In that case, you really want to get them rehydrated so you can reassess if they're perfusing better. And the other potential reason that they are hypothermic is because they are obstructed. So in rabbits that have GI obstruction, they are not able to move and adjust them much beyond their pylorus. And so the stomach is getting bigger and bigger. And in those rabbits, it is the enlargement of the stomach that can compress the caudal vena cava, causing poor perfusion to the caudal half of the body. That's why they appear to be hypothermic. So rabbits that are hypothermia are a worry. They may need to have their stomach decompressed. They're ones that you're going to need to watch more closely. They're going to need additional diagnostics to better understand what's going on with them. Rabbits that are hyperthermic are at risk for having an infection. That may be a respiratory infection. That may be appendicitis. Either way, these rabbits are going to need different therapies than those that are normothermic, and potentially additional diagnostics as well. The other essential diagnostic early on is looking at blood glucose. I kind of broke the blood glucose into 3 groups. So those that are less than 12, they have mild stress. Those are the rabbits that are not going to be as severe. They have a better prognosis. The rabbits that are in the 15 to 20 range, those are hyperglycemic rabbits. So they are painful rabbits. These are ill rabbits. These are rabbits that need aggressive therapy. Rabbits that are above 20 are those that have a poor prognosis. They are in severe pain. They may be obstructed. They are probably going to need longer therapy. They're probably going to need to be hospitalized, and they have a poor outcome, poor prognosis for successful outcome, survival, basically. Looking at the hematocrit or the PCV, anemia is kind of what you're looking for. So if these rabbits are anemic, they may have a liver lobe torsion. They may have another condition going on. So they're going to need additional diagnostic, that being diagnostic imaging. So that's why you check the PCV. So I find that these three are important to do pretty early on. Because it can really also help you gauge response to therapy. So for the rectal temperature and the serum blood glucose, you're not just going to do a one-off. So if this rabbit is hypothermic now, you're going to want to check it again to make sure that it's perfusing later. Or if it's persistently hypothermic, it's going to guide you to different therapies and diagnostics. Same with the blood glucose. You're going to do monitor it initially and then repeat it because you want to see that blood glucose coming down to know that it's responding to the therapy you're giving. Okay, what about sedation and analgesic? These rabbits are painful. And remember, our goal is for a rabbit to be pain-free. I have this little picture down here to remind me what a pain-free rabbit looks like. So the one on the bottom, it's kind of flopped over, it's kicking its legs out. He's a little bit over on his side. That's a rabbit who does not feel pain. So that's always my goal in hospital. Sometimes when they're in the hospital, they're stressed enough that they're never going to look like this, even if they're pain-free, but that is always my goal. My preference is to give initial sedation and analgesic with buprenorphine and midazolam. And I do this because the midazolam helps a lot to get them lower stress from being in the hospital. The buprenorphine works well for me as well. I've been using that the longest. Other options are available. You can also use acetaminophen, but try not to use it for prolonged use because there can be some liver effects with rabbits. But you do want to wait on meloxicam. So you don't want to give them meloxicam until you know that they're rehydrated. And the reason for that is because the rabbits that come in for any sort of GI ileus or stasis, we know that they're dehydrated, and studies are showing that they actually have acute kidney injury because of that dehydration, and giving them meloxicam can worsen that kidney injury. And so we're worried about the long-term function of those kidneys when the rabbits have had meloxicam and they're already dehydrated with this ileus. So wait on that meloxicam until you see that increase in body weight and you know that they're rehydrated. Then meloxicam can be really helpful because certainly GI dysfunction is an inflammatory disease, and so they can benefit from meloxicam once they're hydrated. The other thing is you want to get that CRI of lidocaine started ASAP, again, because of better outcomes. And the lidocaine is a profound analgesic. So you can actually drop the dose in some of your other analgesics if you've got that CRI of lidocaine going. Others are using fentanyl as well as ketamine. You know, it really depends on what you have available and what you feel comfortable with. All right, so there's quite a bit in the literature about using opioids. Does it slow GI motility? How much should we be worried? And the answer is maybe the opioids might be slowing GI motility, but do we care? Basically, I don't. And the reason I don't care is because these rabbits are in pain, and we know that pain will slow GI motility in rabbits. We know rabbits that have arthritic pain are going to have more occurrence of GI dysmotility than rabbits that don't have GI or arthritic pain. So pain alone can slow the GI tract, and we want to get that GI tract going. So my goal is always to get them pain-free in hopes that I can overcome the kind of slowing of the GI tract with fluids and other things that may be happening because of the opioid I'm giving. The literature is mixed, I will tell you, on buprenorphine. So there are some studies that are showing buprenorphine is causing GI motility. Others are saying it's not clinically relevant. We do know that hydromorphone, morphine, and butorphanol do slow the GI tract. Tramadol and methadone don't. So those are all kind of things to keep in mind. Okay. So I've already expressed my like for the CRI of lidocaine. I don't love starting IV catheters right away in rabbits, but the lidocaine is worth it. And that's because it has profound analgesic, anti-inflammatory, prokinetic, and anti-endotoxic effects in rabbits. And so use it. It is a good thing. I put this little picture of this rabbit over here because I just think she looks so judgy. So anytime you have a rabbit coming in for GI ileus or stasis or any sort of motility worry, I want you to remember this rabbit and picture her over your shoulder going, why aren't you placing the IV catheter? Why aren't you using lidocaine? There's better outcomes. Just go ahead and do it. So the reason it seems to work so well is that across species, no matter what has been studied, The lidocaine has prokinetic effects. It decreases inflammatory factors. It decreases prostaglandins. It works on excitation of intestinal muscles. And in rabbits, we know that they have improved food intake when they're on a CRI of lidocaine. They have improved fecal output and have reduced MAC. So that reminds us that it is an analgesic. But the anti-endotoxemic effects are kind of the most surprising for me and potentially the most beneficial. So rabbits have all of these microbes in their GI tract all the time. And when they're healthy and the GI tract is functioning normally, those microbes are in a good balance. A good balance of good microbes and those that are problematic. So some of the problematic ones are Clostridium. Rabbits are known to carry Clostridium, and anytime they have a change in GI motility, they can actually have a dysbiosis or an overgrowth of problematic bacteria. The biggest worry is an overgrowth of Clostridium because that can cause endotoxemia and can actually be fatal for the rabbits. So if you have them started on lidocaine early, that's actually protective as you try to better understand what's going on with their GI dysfunction and whether or not they should be on antibiotics to protect them from endotoxemia. But the lidocaine will have some protective effects there. Okay, so we've already talked a little bit about fluids, but I really want you to prioritize fluids. And the reason is because they will be dehydrated in that GI tract, guaranteed. And the more you can get that GI tract rehydrated, the more likely they're going to be able to overcome what the motility issue is, especially if it's something like an obstruction. I tend to go very aggressive on the fluid. So how aggressive? I kind of aim towards the 200 mils per kg per 24 hour. Now, this is by far at the top end. The truth of the matter is usually when the rabbit is coming in that first 24 hours, it's hard to actually get to that 200 point. So that's part of why I aim for that. Now, it is rare, but possible to fluid overload a rabbit. Usually those that get fluid overloaded are ones that have heart issues. So those are going to be the older rabbits, ones that have murmurs. Certainly, if you know there's a heart issue, then you want to go ahead and reduce the fluid rate. You also want to continue to monitor the weight to know that they're gaining weight. And when they get near the goal weight, that's a 10 to 15 increase in the body weight, go ahead and taper the fluids. If the feces start to come, go ahead and taper off the fluids. Sometimes subcutaneous fluids can be really helpful. I have one case that just always sticks in my mind. And this rabbit came in overnight. So the emergency team was caring for her. They got an IV catheter into her. She was a pretty small rabbit. She came in with a blood glucose of like 13 or so. So it was high, but not too worrisome. And every time I called to check in on her, her blood glucose was higher. And so after she had an IV catheter for about 6 hours, her blood glucose was up to 17 or 18. She was on IV analgesic. She was on that IV CRI of lidocaine. And I thought, what is going on? So we kind of maxed her dose on all of those things up to the fluids. And at the next check, her blood glucose was 19, could have been even 20. And I thought something's not right here. I thought maybe the IV catheter is not in. The night team assured me 100% the IV catheter is in, there's no problem, there's no wetness. And I thought, well, let's just go ahead and give her subcutaneous fluids because maybe the IV rate is just not fast enough and we just cannot give her what she needs. So we went ahead and gave her a pretty big dose of subcutaneous fluids because I was just worried something wasn't right. At the next check, the blood glucose was down. So it was down to 15. So we were headed in the right direction. The next morning we did a CT for her and all of the contrast was in her arm. So that IV catheter was not in all night. She had just been getting that CRI of lidocaine into her arm. And so thank goodness we did the subcutaneous fluids because that was in a more appropriate dose. So we were able to get the catheter in her and then get her on the right track. But that, if I had not been monitoring that blood glucose, I would have missed that she was not headed in the right direction. So I always recommend doing a serial monitor of blood glucose to know how these rabbits are doing. All right, I get so many questions about prokinetics, antiemetics. What should we do here? So fluids themselves are going to be prokinetic. That's going to get the GI tract moving. IV lidocaine, also a prokinetic. Syringe feeding is a prokinetic as well. So just that chewing action will get the GI tract moving in the direction we want it to. I also offer favorite foods in the enclosure, because sometimes when the rabbits are seeing their favorite foods, they'll go ahead and chew on it. Maybe they're not really eating much, but that chewing action again is moving the GI tract in the direction we want. So I also like mirapatent and ondansetron. These are two antiemetics, and everyone kind of at first will say like, wait a minute, rabbits can't vomit. Why are you giving them antiemetics? Well, I'm not trying to prevent them from vomiting. I'm trying to prevent them from feeling nausea. And so you use both of them. So mirapatent is not a true anti-nausea medication. It is more of an antiemetic, but it's more readily accessible. It can kind of take a little while to have effects. It's about an hour after you give the injection before the animal starts to feel the effects. And so that's why I also like ondansetron. Ondansetron works almost immediately. It is truly anti-nausea. And so I tend to use them together because the ondansetron works quickly and can stop the nausea, and the mirapatent kind of takes over from there. Ranitidine, there's some literature to say that it can reduce GI pain because of ulceration and may have some prokinetic effect. It's not wrong to give it. If you can give it, great. It's probably not critical either. Metoclopramide. The studies are showing it's probably a weak promotility. We always think of it as a prokinetic, but it probably is not as much of a prokinetic as we think it is. It probably is a stronger antiemetic. It's not wrong to give it. I tend not to give it because by the time we get to this point, that's a lot of medications to be giving the animal. But if you're comfortable with giving it, it would be fine to do. Cisapride, we do have studies to show that cisapride does not improve GI motility. I'm in the United States, and this one's actually difficult for me to get. So it's pretty rare that I'm giving that. So I actually kind of skipped that one. But if you have it, it wouldn't be wrong to give. It just may not be working as well as you think it is. So what about the rabbits is presenting with respiratory abnormality in addition to this GI issue? So rabbits are obligate nasal breathing species. Anytime there's a respiratory infection, rhinitis, sinusitis, upper, lower respiratory infection, that's going to cause them stress because they cannot breathe easily. That stress is going to cause them delayed GI motility, and it will also impact their hydration. So these rabbits, because they're tachypnic, they become dehydrated pretty quickly. And that dehydration can also cause them to have a secondary GI ileus or stasis. So for these rabbits, we want to get them on oxygen quickly because that will help them oxygenate, reduce the stress on their heart. And you probably want to reduce the fluids that you're giving these animals, and also potentially reduce the opioid as well. If you can, put a pulse oximeter on them so that you can see how well they're oxygenating, maybe increase their oxygen based on that. Any rabbit that has respiratory abnormalities or evidence of a respiratory infection, I go ahead and start them on azithromycin, and I do that quickly because often they're better after the first dose. And we want to get these rabbits breathing normally, so it decreases their stress as well as stress on the heart, and then also can help reduce the tachypnea and improve their hydration. So azithromycin has great antimicrobial spectrum for the respiratory tract in rabbits and great tissue penetration as well. All right, so back to the rectal temperature. We've talked about this quite a bit, but I want to talk a little more about those hypothermic rabbits. So once you've gotten them rehydrated, if they still are hypothermic, then they may have GI obstruction. And again, that's because the stomach's getting so big that the caudal vena cava is compressed. And for rabbits that are hypothermic, you want to give them fluids that are warmed, and that's because they need fluid or thermal support. Now, the biggest issue is perfusion, but thermal support, either warm forced air or warmed fluids, are going to be good for them. Okay, so let's talk about those that might be obstructed. So I've got a couple radiographs here. Radiographs are going to be your go-to for rabbits that you think might be obstructed. So those that are hypothermic should get radiographs, and this is what you're looking for. So the big images here are actually normal rabbits. So I want to point out in the picture in the bottom, that rabbit has a ton of ingesta, right? Well, that's actually normal. So there's two things to look at. So in this rabbit, the ingesta in that stomach does not extend beyond that second lumbar vertebra. So in the radiograph kind of at the top, the stomach is extending beyond the second lumbar vertebra. And that's kind of one of the diagnostic criteria for looking for obstruction radiographically in rabbits. The other is looking at whether or not the stomach touches the ventrum, or kind of the sternum area. So you can see in the normal rabbit at the bottom, there's some space. You can see some space between the skin and the stomach on the ventral aspect, whereas the rabbit that's obstructed in the top, there is really no space there. So that stomach is pushing far more ventrally and more caudally. So this rabbit is probably obstructed. If it's not already on a CRA of lidocaine, it should be. The next thing for that rabbit is going to need orogastric decompression. So that's basically where you're placing either a nasogastric tube or an orogastric tube and removing the Angiesa that's on the stomach. The rabbits that are obstructed or suspected to be obstructed should not be syringe fed. And if they were, then you're going to want to do the orogastric decompression to try to get as much as possible off of the stomach to remove this, to reduce the size of the stomach. Other things to consider, if these rabbits are not improving, they may be surgical. But I do want to remind you, if you can get them decompressed, if you can get the fluids going and the IV lidocaine, they may be able to be managed medically. Rabbits that cannot be managed medically are those that are going to have persistent hyperglycemia that's maybe getting worse, closer to that 20, or maybe have hyponatremia. Those are going to be more likely to need to have surgery. Okay, so you have the patient, it came into you a few hours ago, you've done all of the things, you've gotten it on the IV fluids, you've already done some subcutaneous fluids, you've gotten the temperature, you've checked the blood. So now your question is, should I be sending this rabbit home, or should I keep it hospitalized and continue IV therapies and aggressive therapies? And it's always tricky to decide that, but these are the criteria that I look at. So on the left, we have all the rabbits that can be managed as outpatients. And then on the right, those that need to be hospitalized. So the outpatient rabbits, the ones that can go home, are going to have low blood glucose, so under 12, be normothermic, have a normal PCV, and are hopefully producing some feces. Those can go home on subcutaneous fluids, oral analgesics, nutritional support, but you want to see them back the next day. And the reason you want to see them back the next day is you want to make sure that they're producing feces. They should be producing more than they were the day prior. You want to make sure that they are maintaining their body weight. And if they're not, then you're going to need to up the fluids. You also want to make sure their blood glucose is lower at recheck. Because if the blood glucose is lower, then that means that they are responding well to therapy. Now, for all the rabbits that need to be hospitalized, those are going to be those that have a blood glucose higher than 15. They're hyperthermic or hypothermic. They may be anemic. Maybe they have no feces that are being produced. And maybe these are the rabbits that have had a recurrent ileus in the past 3 months or so, because those rabbits are probably having a more severe underlying disease that's contributing to their stasis episode. For those, you're maxing out the fluids, you're maxing out the analgesics, and you want to recheck them hourly or every 2 hours to adjust the therapy. These rabbits also need diagnostic imaging. So what do they need? Radiographs, ultrasound, or CT? Well, if you have a CT, just run them through the CT. I recognize it's not always possible, so radiographs can be helpful and ultrasound can also be helpful. These rabbits also should have full blood work along with their serial blood glucose monitoring. Okay, so we've talked a little bit about obstruction. How do we know if they're going to be surgical or medical? It's always tricky to decide this. About some methods you can use are also serial radiographs. So you want to watch for passage of gas and reduction in that gastric size. So perhaps you have a rabbit that has the big stomach, it's probably obstructed, you decompress it orogastrically, and then you want to do serial radiographs. So this is actually an example of a rabbit who initially was looking obstructed, and then they could see the gas kind of moving further caudally as they did the serial radiograph. So this rabbit was able to be managed medically and did okay. So that's something to look at. All right, what about other things? What about appendicitis? So appendicitis is something that I worry about in rabbits that have recurrent ileus and stasis, but don't have any sort of dental issues. So dental malocclusion is a common cause of recurrent ileus or stasis. But if their teeth are okay, or maybe you've already corrected the malocclusion, then I worry if they have appendicitis. Now, these sometimes will be hyperthermic, but they might be normothermic. And the diagnostic that you're going to need to identify these is probably CT with contrast. Now, there are definitely publications out there that can be diagnosed with ultrasound. You cannot diagnose it with radiographs. And I say you can diagnose it with ultrasound because There is no way that I'm going to be picking up on appendicitis on ultrasound. I am not good enough. What you're looking for is a thickened appendix and that may have micro abscesses in the wall. So I can see it pretty clearly in the CT. Hopefully you can as well. So here the purple is actually showing this big appendix. The green is actually sacculitis. So often they'll have sacculitis along with appendicitis. So here you can see it in this other view as well. And I believe that the blue is pointing out what they thought was maybe a micro abscess or some sort of abnormality there at the end of the appendix. And this rabbit went to surgery, and sure enough, it had a big appendix. It was full of pus. They removed the appendix and it did really well. This rabbit, I think it had a few instances where it had stasis or ileus in the year prior. And it always improved on medical therapy, but ultimately it was this appendix that was flaring up each time. And it wasn't until they removed it that it did well. So what about liver lobe torsion? So this is one that I always worry about. These are often rabbits that have normal blood work, but are very painful. And these are usually painful in the upper right quadrant of the abdomen. Not always there, but that's where the caudate lobe of the liver sits. And that's usually the lobe that flips. So in rabbits with liver lobe torsion, what happens is a portion of their liver actually flips and kind of rotates around the stalk of it. That portion of the liver does not have normal blood flow and then ends up necrosing. That's extremely painful when that happens, and they have better outcomes if that's surgically corrected, although they don't have to be surgically corrected. They can be managed medically. Often if they're managed medically, these are rabbits that will come back with recurrent ileus because they're still painful over a long period of time. Their liver's not quite functioning correctly. I actually had one case where the liver lobe flipped, like it flipped and rotated and then it flipped back. And so those liver lobes are more mobile than we sort of expect. But anyway, the way to diagnose this is through ultrasound or through CT. If you're looking at them on ultrasound, you're looking for blood flow. And usually if this has happened not so recently, you will see a necrotic lobe of the liver. This is actually a CT image, so you can see this is a distended gallbladder, this kind of light green image or arrow, and then you can see the torsed lobe is on this pink. And the reason you can tell it's torsed is you can't see any sort of blood flow in there. So this rabbit had contrast, so you should see some contrast in the liver lobes, like in this purple arrow area here. So this one had a caudate lobe, liver lobe torsion. And surgery is ideal, but some of them can survive with medical management only. Anemia is the most common abnormality in the blood work, but not always. Sometimes there's increased liver enzymes, sometimes there isn't. So this one I want you to be on the watch out for. So gastric dilatation of volvulus is not reported yet in rabbits, but it does happen. At VET.CT, we've seen, I want to say about 10 cases of these in the past 2 years. I would say it's rare. So this is all the rabbits that are getting CT. So these are pretty severe cases that are getting looked at VET.CT. And among those, there's been about 10 cases. So this one here is pretty dramatic. So you can see that in this picture kind of on the left, this would be a normal rabbit, no flipped stomach, whereas this one here is completely flipped. So the pylorus is the green, so it should be up here. But in the rabbit with GDV, it's down here. And this one, amazingly, they caught it quickly. And they really were expecting it to have liver lobe torsion because it had a severely elevated ALT. But the reason this happens is because there's intrahepatic biliary distension because there's obstruction at the porta hepatis. So when the stomach flips, it impacts the portal vein, hepatic artery, and hepatic duct. And so the ALT just zooms up in these patients. And so they can look on blood work like maybe they have a liver lobe torsion, but it's actually a GDV. These, the clinician had noted that had a really distended abdomen, really firm stomach. So they were expecting a liver lobe torsion or possibly just an obstruction. But in this one, it was a true GDV. They got it to surgery and it survived. Unfortunately, not all of the rabbits will survive because they need surgery quickly. So in summary, I have kind of a list here of the worried the worry ones, right? So if it's a straightforward ileus or stasis, we can manage them with medical care. But if there's an obstruction, liver lobe torsion, appendicitis, or a GDV, those are going to need additional imaging. They're going to need additional therapy and possibly surgery. So I just kind of summarized here some of the findings that you might have with those. And then I wanted to leave you with my judgy rabbit friend who's going to sit over your shoulder. And the next time you have a rabbit with ileus or stasis or any sort of GI issue, remember this rabbit is saying, where's my lidocaine? Give that rabbit lidocaine. There's better outcomes with lidocaine. So, thank you, everyone. Today, I really appreciate your time. And now we do questions.
Yeah, that's great. Thank you, Copper. It's really good. I particularly like the decision tree around hospitalization and not. I think that's a really difficult area to know, and often owners, they don't want to pay for hospitalization or not. And I think it's a really helpful decision tree, that actually, because I've certainly been in that situation.
Yes, it's tough. I agree. But so I do this kind of mentally, and I thought it would be nice to have it laid out so you could see.
Yeah, no, it's a really useful thing, really useful pragmatic route. So yeah, great. So we've got a number of questions. So let's crack on with the questions. Okay, so these were sort of posted throughout, and if you've got any questions now, please post them down as well. I've certainly got a few questions as well. So first of all, which is a really relevant question, I wouldn't be able to answer this actually. What is the normal temperature of a rabbit?
Oh gosh. So the problem is I use Fahrenheit.
That's all right. I've got Google in front of me, so we can.
So ask me the next one, and I'll see if I can look it up and give you the conversion.
Yeah, that's fine. So, what dose of lidocaine IV would you use?
Oh yes. So here I've got the lidocaine, and you would ask me, and of course I always have to look it up myself. So the CRI is anywhere between 75 to 100 micrograms per kilogram per minute. And that's the initial. You can give them a loading dose of 2 mg per kg, but you don't have to. So the studies are showing they do equally as well with or without the loading dose. So if you want to keep the math easy, you can just plan to start at 75 to 100 micrograms per kilogram per minute.
Okay. And that's a CRI. That's not an intermittent bolus, is it?
Right. That's a CRI.
Okay. Because
so right now we don't have studies to show us if we can do an intermittent bolus. So I just don't know. Okay,
because one of the questions that just down the line was how often can it be repeated? But obviously with a CRI, that's a continuous rate infusion as well.
Yeah.
So yeah, okay. Quick question about analgesia. So what would your first line analgesia be for GI stasis in a rabbit? And is it different if severe stasis or an elective procedure, e.g. a healthy rabbit? So first line analgesia, and is it different between severely ill stasis rabbit or elective analgesia?
So my preference is buprenorphine, and my preference is to do buprenorphine with midazolam. And now I know midazolam is not going to be analgesic, but it's going to help with the sedation portion. And so we think that the sedation portion can also help with kind of the more severe cases. So if it was kind of a mild case, I would actually start with buprenorphine, because even though the rabbit may not seem that painful, they are more painful than they're letting on because they're a rabbit. And I use buprenorphine again too, because I've just been using it the longest. That's just the one that's been around the longest for me, and I'm comfortable with it. But other options are reasonable. So hydromorphone would be a reasonable option as well. And I saw one recently where they had started with buprenorphine, but it didn't seem like that was working enough. So they added on acetaminophen, and then the rabbit was just fine. Like, she was very comfortable after that.
Okay.
Let me tell you the temperature. So the normal rectal temperature for rabbits in Celsius is 38.5 to 40. So basically, if they're under 38, they're going to be hypothermic. And those are the ones that we really worry about. Oh gosh, there's 17 questions now.
Yeah, I know. This is another really good one, which I've always thought about when I was treating rabbits. Is there a preference between legs or ears for IV cannulae?
I think that, so there is truly no preference as long as you're going in the ear vein. So in the US, we're trained on the leg. So I do cephalic always. I've actually So in that rabbit, I gave the example where they had blown the IV catheter overnight. That one, I actually did a saphenous catheter. So in the back leg, because that was the only vessel. The rabbit was otherwise so tiny I couldn't hit the ear. I think it's whatever you're most comfortable with. I understand in the UK, most people use the ear vein, and that's great. In the US, people often want to go for the big vessel in the ear, which is the artery, and then they cause thrombosis. And then those rabbits end up with big holes in their ears, and obviously we don't want that. So if you're truly going in the vein, I don't think it matters, whatever is most comfortable for you.
And a question on liver lobe torsion. Is there a situation where liver lobes need excision?
Yeah, so the studies now are showing that rabbits with liver lobe torsion will have better outcomes if it's surgically corrected. That being said, the majority of the ones I've seen were managed just medically, and I believe they all survived. So this is kind of a controversial aspect because there are studies that looked at normal rabbits in a lab that were euthanized for laboratory reasons. And a significant proportion of those had liver lobe torsion as incidental findings in necropsy. So this happens somewhat commonly in rabbits. We don't exactly understand why, and often they survive it. And so I tend to go for medical treatment unless it's really painful. The blood glucose is still going up, even though we're maxing out all of the medical support. The other thing is I treat them all medically initially, because if they are headed for surgery, you want them to be the most stable headed into surgery, but sometimes they do need surgery.
Okay. And back to lidocaine a little bit, but are there any contraindications for lidocaine CRI?
Yeah, so the contraindication is known bradycardia. So if you have a rabbit that has severe heart disease and it's bradycardic, then it should either, well, the studies actually looked at still giving them a CRI of lidocaine, but just going low dose. And they found that they were able to not worsen the bradycardia with lidocaine if it was low dose. I don't remember what the dose was, but they did okay with the lower dose, maybe even below the 75, but they just watched the bradycardia really closely.
Okay. Question on sedation protocols. So do you have a sedation protocol, or what sedation protocol would you use for taking x-rays on sick rabbits, on these types of sick rabbits?
My preference is just buprenorphine with midazolam. And if they're not sedate enough for radiographs with that combination, I just give them either more of both buprenorphine and midazolam or just more midazolam. And I find it works really well. Often we're going slowly. So we're just slowly putting the rabbit in lateral, slowly turning the rabbit over, and they always tolerate it.
It's great to know. So thank you for a very interesting talk. Would you stimulate chewing even if you suspect a blockage?
Yeah, I think I would. And so those sort of, what would you do? So those would be the cases where I think I would put in whatever its favorite item is. So like if it loved cilantro, or maybe it loved a dandelion, I would put it in there in hopes that he would chew it and not necessarily consume a lot. So the big thing is not adding more volume to that stomach with obstruction, but getting them to chew, because that prokinetic effect is going to help hopefully move the blockage.
Quick question on glucose sampling. Do you just use a dog-cat glucose monitor, the proprietary ones?
So yes, that is what I do. There are some studies that will show that there's some differences, and I don't remember which one's best, dog versus cat, because in truth, if I'm going to be doing it serially, it doesn't exactly matter that it's a precise number. I'm just looking for change in trend. And you can say, well, wait a minute, you gave us cutoffs with the outpatient or hospitalized. Well, even those cutoffs are a guesstimation, really. And so if they're under 12, then even if that blood glucose is off by a couple, then I know even if it's 14, they're probably going to be okay. It's really that 15 and above that you're going to worry about. But yeah, a dog cat blood glucose monitor. I think I've used human ones as well, kind of whatever I've had.
Yeah. How do you feel about IV paracetamol use for analgesia?
So we don't have access to IV paracetamol, so acetaminophen. We don't have access to that in the US. I just haven't done it, so I don't know for sure. I can't comment.
Okay. And what form of fluids would you use for general fluid therapy?
So again, our fluids are a little bit different over here. So I use lactated ringers, or what we call Normasol. So it's going to be a normal distribution of electrolytes. I'm not sure it truly matters. Where it may matter is if you have a rabbit that's already hyponatremic, then you're going to want to look more closely at that. But initially, I think any fluids are good as long as you're trying to get fluids into them.
Right. It's a good question here, actually. If owners don't want to hospitalize, what sort of dose do you use for subcutaneous fluids?
Again, I go at that 200 mils per kg per 24 hour. Now, it also depends on what fits in the rabbit. So that's part of why I give some at initial. So like right when they're in and you're doing an exam, I give some fluids then. Because if the owner is going to refuse hospitalization, I want to really maximize how much I can do subcutaneously to send them home. And sometimes you're restricted by just how much sub-Q space they have. But I try to go towards that 200 mils per kg per 24-hour period.
Okay. For patients that can't be hospitalized due to financial concerns, would it be worth giving them a loading dose of lidocaine just before sending them home? Is that still worthwhile?
So I think possibly. We don't have studies to say for sure, because none of the studies that I've looked at CRIs of lidocaine looked at kind of a short period and then no more lidocaine. But I don't know why it would be contraindicated. So if it's going to be anti-endotoxemic and it's going to have anti-inflammatory properties and prokinetic effects in those initial moments, it's going to be better than none, I would think, but we don't have a lot of studies to say for sure.
Okay. One here about a obstructed rabbit. So it had a case with pretty obvious obstructed rabbit through palpation. Unfortunately, after the initial examination, it crashed, and it was a giant rabbit that presented with a glucose of 23 and dramatically low heart rate. In severe cases where you think an imminent crash is going to be anticipated, would you recommend administrating drugs such as atropine?
That's probably, so it's a good thought. So in those that are going to crash, or I'm worried about them anesthetically, I'm going to anesthetize them, I do draw up emergency medications such as atropine, epinephrine, things along those lines, but you're going to need an IV access. So I would still sedate it. If you knew it was obstructed, perhaps I would heavily sedate it and prioritize nasogastric decompression. But there's risks with all of those things. So unfortunately, I don't know that one would have had a good outcome. There was a study that looked at I think it was 23, anything over 23 on the blood glucose, all had a fatal outcome. In one study. That doesn't mean that's true for all cases in life, but in that one study, they all did.
Any thoughts on metamizole for analgesia? Now, from what I understand, metamizole is banned in the US and the UK, I think.
It might be why I've never heard of it. I just don't know.
Yeah, I think it's a painkiller of some sort. Maybe that's antispasmolytic type scenarios, but I'm pretty sure it's banned in the UK and US off the top of my head. So, okay. We've got a question about IV fluid rate. Do you use? And I think we've covered that with the 200 ml per kilo.
I basically go as fast as they can tolerate it, almost. You're somewhat restricted by the size of the catheter. There's one study that showed better outcomes in rabbits that had a mean of 160 mils per kg for 24 hours. So that's kind of lower than what I kind of aim for. But that study, that rate is still higher than most published recommendations. So that study kind of reminded us that often they need a high fluid rate.
Yeah. Great. We've got a question from Felipe just about x-rays and what drugs would you use? So that was more the analgesia and sedation protocol that I think you've touched upon there.
Everybody's familiar with something a little different, and they may have different medications, I would say just kind of use what you're familiar with. For me, it's buprenorphine and midazolam. I find that works really well.
And dose of meloxicam off the top of your head that you used?
Yes. So remember, don't use meloxicam until they're well hydrated. But once they are well hydrated, you can go at 1 mg per kg per 24-hour period.
Okay. Okay.
And there's studies to support that they do well with that, even if you give it for as long as 28 days.
Yeah, great. Do you find rabbit pain scores useful, or do you base them on blood glucose measurements instead?
Yeah, I don't do the pain scores. And in part, I did not learn them in my initial training. So part of it is I struggle with anything that's a score, because I feel like it's still somewhat subjective, in that what I may think is a grimace, you may not think is a grimace. And so I prefer things that are less subjective. And so for me, I find that blood glucose is just such a good indication of the therapy overall. And so it's not just pain, right? So it's also stress, it's also perfusion. And so for me, I like the blood glucose better than a pain score.
So a quick question about subcut fluids. Do you use lactated ringers or sodium chloride? And is there a maximum amount? Are there any risks like necrosis that we can consider as well, just with subcuts?
Yeah, so I use lactated ringers as my preference. I probably have used just saline. Saline is irritating when given subcutaneously. I don't know that I can always appreciate that, but technically it should be more irritating than lactated ringers. So if I can, I'll do lactated ringers. And I just really give them a lot. And I have not encountered any problems. I've not had any fluid overload with lungs or anything like that. They're not a rat, or they're not like a cat. If they do, there can be cardiac overload with too much fluids in general. So certainly you could do that with subcutaneous. I've never seen tissue necrosis, but I also don't give it until the area is hard. So I give it while it's still soft. Sometimes I'll massage the area while I give it. I had one that I gave just a lot of fluids subcutaneously, and it came back the next day with just all of it was just kind of sitting on the chest. So it just kind of moved down the back to the chest. But that's not really a complication. It just moved. So I wouldn't recommend giving it until the skin's too taut. Make sure it's still soft. But otherwise, I kind of go on the high end.
Any thoughts on mirtazapine for appetite stimulants?
Yeah, I think it's a good thought. I don't think I've ever used it. There's a chance I have. I just don't remember. I think it's worth a try. I don't know any reason why you shouldn't. So I think it's fine.
And back to buprenorphine and midazolam, do you give them at the same time? What route and what type of dose?
Yeah, so the buprenorphine dose is 0.02 to 0.05 milligrams per kilogram. And the midazolam, I usually do around 0.2 milligrams per kilogram. And the range on the buprenorphine I give depending on how painful the rabbit seems to be and how grouchy. So if it's a particularly grouchy rabbit, I'll go on a higher end of that buprenorphine, or if he's painful. And with the midazolam, I almost always just do 0.2 mg per kg. And I probably have gone higher than that if I needed them very heavily sedated, but that's kind of the range I normally do. And I usually give it IM, and I combine them, but you don't have to. I usually combine them.
Okay. So similar sort of question. I think it's worth just going over again, though, just briefly. Many rabbit owners are financially challenged. The best analgesic is prokinetics to use, which I think you've covered, but it'd be worth going over again. And just the subcut fluid admin if the owner can't afford a hospitalization or much way of diagnostics.
Yeah, if the owner really can't afford much, that's part of why I start with checking the body weight and the body temperature. Those are inexpensive items that are going to tell you a lot of information. And then that blood glucose is not that expensive either. And that's also going to help the owner know the prognosis. So you can say, like, oh, look, this blood glucose is over 20. You know, we can send this rabbit home, but it's unlikely to survive, and maybe help guide the owner that way. If the owner is just saying, no, I'm not going to do anything, then analgesics, whatever the least expensive option you have is, and fluids are going to be the most important.
Quick one on lidocaine CRI. Again, just would you use it during surgery?
Oh, yes, you can.
Great. Partly for analgesia and just the sort of
Right. Yeah.
effect. Yeah. Okay. Methadone has minimal. You said that methadone has minimal GI effects. Why buprenorphine over methadone?
It's just because I'm old. And you know, for us over here, methadone has not been as accessible until kind of recently. So if you're more familiar with methadone, go for it. It's just my personal preference.
Okay, that's great. And what are your thoughts on antibiotic use with GI stasis?
Yeah, I was afraid you're going to ask. So I tend to give antibiotics. Most people would recommend not giving antibiotics, but I do. And the reason is because I've seen a couple of those endotoxemic cases, and they die quickly. And I don't want to encounter those anymore. So either I give enrofloxacin or I give metronidazole, kind of depending on the case, depending on the day. And because I just would rather not end up with an endotoxemic case.
That's great. And although we've covered it again, I think still worth saying, because we may have missed it earlier, just what kind of dose of buprenorphine and midazolam do you use again?
Oh yeah, so buprenorphine dose 0.02 milligrams per kilogram to 0.05 milligrams per kilogram, and then midazolam is 0.2 milligrams per kilogram, and they can be given together. Higher end of the dose range for the buprenorphine if they're more painful. So like the liver lobe torsions tend to be more painful. Obstructive cases are more painful. Or if they're grouchy. So if they're really grouchy trying to bite me, don't want them biting me or the IV line kind of thing.
Okay. Right, we're really still going. This is great.
Oh gosh, 32 questions. Oh my goodness.
Okay, probiotics.
Oh yeah.
Probiotics and diet and water management.
There's nothing wrong in giving probiotics. There's a little bit of controversy about giving them probiotics while they are in an active stasis or ileus. So the controversy is because if you are giving probiotics and they already have a dysbiosis, the probiotic can worsen the dysbiosis. The other thing is a route of administration. So the rabbit has a very acidic stomach. Not too much is making it, not too many microbes are making it past the stomach. They make it past the stomach in the form of the cecotrophs because they're like all encased in this little fecal pouch thing, so they can make it past the stomach. But there's some thought that the probiotics are not making it past the stomach, and if they do, they may not actually really be helping. So right now, I don't give probiotics. If the owner is really enthused about it, okay, fine. Once they're doing well overall, they can start them. But getting them on high fiber diets are going to be better at reestablishing normal GI bacterial, sort of reestablishing the appropriate levels of good versus bad bacteria are going to be more dependent on that fiber and getting them eating fiber regularly, more so than giving them a probiotic.
I think we've covered antibiotics and the GI stasis. Jennifer's apologizing for the last minute questions. Do you use buprenorphine IV?
I mean, I probably have. Yes, probably. I don't know. Yes.
But your preferred route is IM, is it?
Yeah, again, probably just because I'm old. And again, you know, like I'm doing that in the beginning, and they may or may not be on buprenorphine the whole time, depending on how they're doing with the CRI of lidocaine and things like that. More commonly, I'm working with folks that want to add in ketamine and want to add in hydromorphone. You know, like it just depends on what you have. And I'm not sure route of administration really matters. Again, the rabbit will tell you, you know, if the BG is not coming down, then you need to rethink what you're doing. If the rabbit's still acting painful, otherwise, you need to rethink what you're doing.
Right. And the last one at the moment, I presume this is, what are your thoughts on endoscopic fecal transplants for gut flora?
I mean, maybe it works. I don't know, like, for rabbits, have not had cases where we really needed to seemingly reestablish normal gut flora. And they've all done well with a high fiber diet. Like usually rabbits that are having issues with dysbiosis intermittently or recurrently are rabbits that are not on good diets. They are getting pellets. They're not getting either fresh grass or grass hay. That should be the majority of their diet, with a little bit of maybe pellet. They don't actually need pellet, maybe pellet, a little bit of vegetable or fruit as a treat. So rabbits that are having dysbiosis usually are on a suboptimal diet. I have done endoscopic fecal transplant, rectal fecal transplants, but not in rabbits. And it's a lot of work, and I don't know if it works. Like, it's a lot of work to do it, and I don't know if it's effective.
Okay. A couple more if you're okay, and I think we maybe have to call it a day at that point, but thank you for all your questions. Adansatron in rabbits, are there any studies do you know of in rabbits? No. So
No, I don't think there's any studies. The nice thing about rabbits is they're used as lab animals. And so there's a lot of sort of initial safety studies that are done in rabbits. And so there's a chance that that has been done. I don't super remember. I usually try to look that up. I just don't remember. So, but I don't know of any great studies.
Yeah. And probably last question, I think, do you check blood glucose hourly? Or how often do you check?
Hourly is kind of my goal, at least initially. I would say in practicality, I can't actually do it that frequently. Like we're doing other things, it's a little bit unlikely. So maybe every 2 hours is a little bit more realistic. In that rabbit where I gave the example that the blood glucose was climbing, even though it was on IV fluids and CRI of lidocaine, that one I think we were doing hourly, because I was just so shocked that it was going up and up and up. And so that one I think we were doing hourly, but it's as frequently as you can. Like if it's stable and we're going down, you don't need to check it as frequently. If it's going up and up, you want to be checking it frequently.
Yeah, that's great. Okay, I think we're probably call it a day there, actually. Copper, that was amazing. Obviously,
Yay.
Hundreds of questions, and I think rabbits just pose those questions. They get very ill. We care for them so much, and they're difficult patients to treat. They really are, but so rewarding as well. So that, for me, has been a massive education as well. I'm sure everyone else. I think we've got 1 or 2 more slides just for me to sort of finish off.
Sorry, yeah.
If you're right to just flip it right to the end, that'd be great. So yeah, please, thank you for joining us tonight. If you've got any more questions, do use us for cases. We're open for advice. Download the app, like I said, on your phone. My phone's just died, but download the app, and it's really useful for contacting us, and you can have continuous chats through that as well. When you submit cases, use us for intermittent cases on a pay-as-you-go basis, or if you do find you use us more, subscriptions are really useful. If you want to get information on how to access specialist case advice, just contact me directly. My email's there, richard.artingstall@VETCT.com. But thank you, Copper. That was incredible. I knew it would be. But thank you so much for your time. And thank you for joining us, everybody. So
Thank you.
we'll hopefully see you in a couple of weeks' time. So look out for the next talk. Okay. Thank you.